Fantastic, sir. அதான் ஒரு மூச்சு எடுத்தாரு, அத்தனை ஸ்லைடு அப்படியே டக்கு டக்குன்னு சொல்லி முடிச்சாரு. யாருக்கும் டவுட் வரதுக்கு வாய்ப்பே கிடையாது.
Okay.
Presentation. Very nice.
Thank you, Dr. Sudashana.
Sir.
Dr. Sudashana from Secretary IAP Tiruchirappalli and Dr. Soumya IAP President Coimbatore. Thank you, both of you.
Thank you so much, sir.
Thank you. Next session will be chaired by Dr. Annamalai Vijayaraghavan, CCB IAP President. Over to you, sir.
Good evening, sir. I must thank the organizers for this wonderful CME on Smart Pediatric Clinic. I thank Dr. Chenthil, the President, IAP TNSC, Suresh Balan, Dr. K. Rajendran, and the Central IAP, Dr. Muthukumar, National Coordinator, and my friend, Dr. Sunil Srinivasan, the convener. And of course, our Vice President for next year, Dr. Major K. Nagaraju, for his opening remarks. I have the pleasant duty of introducing our State TNSC President, Dr. Aram Chenthil, and he has been the architect for all these programs this year from Tamil Nadu. And he is a senior pediatric consultant from Neyveli. His area of interest include adolescent care and neonatology. He has won the Dr. Balagopal Raju Active Pediatrician Award in 2010. And he is the current president of TNSC IAP. And Tamil is his passion and life. As you can see from here, everything is written in Tamil. And Tamil cells circulate in his blood along with his RBCs and WBCs. A person who believes in simplicity and humility, he has made a great impact in social awareness in the areas he serves. His motto is quality care need not be confined to our consultation rooms, but must permeate into the society. He is going to give a talk on quick triaging. Actually, we had a national workshop, Smart Clinic module in Chennai 3 months ago, and he spoke earlier. And this program actually has added few more topics, and it's wonderful now. Thank you, sir, and over to Dr. Chenthil.
Yes, I'll share my screen. Just tell me if it is visible.
Yes, sir, it started.
Am I audible, sir?
Yes, sir.
I must thank the convener of the Smart Clinic program and whose brainchild has, it has grown to such a large level. And so I must thank Dr. Sunil Srinivasan for introducing this concept. Thank you, sir. And also the opportunity he gave me in dealing with this topic. So my acknowledgements to Dr. Thangavelu and Dr. Ilandren who contributed for this topic. I'm going to deal with the safe OPD during COVID times. We have been now well versed. Registration and classifying outpatients, vitals and anthropometry, and triaging the ill child. So the safe COVID time clinic, we all know we'll have to fix staggering appointments, must ensure that's a minimal waiting time, seating with social distancing, wash your hands, legs with soap, and non-touch temperature recording. All these we have been practicing. So, and after leaving also, they must dip their hands in sanitize also. Consultation with PP and all, we have been, but now we have been in a decreasing trend now in Chennai and other areas. So the prescription is taken by the nurse. So I don't think the safe clinic video I will skip. So the registration of the patients, you can, in a smart clinic, you can give a registration slip to each parent or a caregiver. So ask them to fill their portion, say about the name, age, sex of the child, parent's name, cell number, for what they have come. For a fever or cold or cough or constipation, is any what is the time they have come, a referring doctor whoever it is. These basic particulars can be got. So how then you can easily classify them, whether if it is a newborn that's come for this initial checkup, first visit, for the any illness they have come, or for routine immunization they have come, any review, they require further visits, for that they have come for review of with investigation reports, have they come, or referrals. So they can have a breastfeeding room if you have the space, so that the feeding mothers and the newborn mothers can be observed, helped, counseled during the waiting hours in a separate room exclusively, so that you can tell them about the positioning and attachment to the breast, and you can emphasize on the duration and frequency of breastfeeding. FAQs by the young mothers and grandmothers can be answered. So the child's vitals and anthropometry, weight, height, and head circumference should be recorded. Temperature, pulse, heart rate, respiratory rate, blood pressure, and capillary refill time, partial pressure, and the oxygen saturation. In sick children, you have to definitely include. And so that you can categorize them. You can price them into whether it is sick, ill, or well. So these data to be filled by the staff nurse, and the child's responsibility, each say about 5 or 6, 5, or depending on the OPD crowd, you can assign 2 or 3 to each staff nurses. So you can, at the time, you can give 5 or 10, depending on the crowd you are waiting. So she takes in charge of the child, guides them, helps them, counsels them, and dispenses the medicines, and tells them what to take, how to take, everything. So in our area now, we are going to the examining a child proper. What was the traditional way you used to get the general way is take the history, examine the child, you send it to the lab, treatment, detailed diagnosis of the disease, the lab and treatment. This was the traditional method. But now we have come the pulse way. You, by the first look of the patient itself, or for the baby itself, you have to assess. This is the ABC I'm going to talk about. And next is the primary assessment, that is called the ABCDE approach. That is to be by the doctor. The first one is by the nurse. This is by the doctor. So the life-threatening problem and immediate treatment will be given. You identify a critically ill child based on the physiological status. So what is triage? So in every, say, 100 OP, let us assume there are 2 to 5 children who require hospitalization. Among that 100, one needs a high dependence unit or a NICU or a PICU admission. How to pick up this 1 and 5? That is the thing which is in front of us. So the right child should be picked up at the right time for the right treatment. So this is the aim of this presentation. So the initial assessment in a busy OPD is a quick assessment that helps the triage nurse identify those patients requiring immediate care from those who can safely wait. You have to categorize, differentiate them into 2 categories. A rapid triage assessment starts with an across the room. In fact, it starts as the baby or child enters with the caregiver or the parents. So seeing the child's appearance as he or she enters the OPD is the beginning of the rapid triage assessment. So the qualities of a triage nurse is she needs a good sense of what constitutes normal for children of that age. This knowledge will make it easier to recognize things that should be concerning. For example, a 6-month-old child who is not interested in her surroundings, or a 2-week-old baby who is difficult to arouse to feed. So the triage nurse must be comfortable interacting with children across the age spectrum and must be well versed in the anatomic and physiologic issues that may put a child at increased risks, as well as certain age-dependent red flags that should not be overlooked. So she requires a basic knowledge about pediatrics. So the pediatric assessment triangle, this is the basis. So appearance, work of breathing, and circulation. This will be the quick assessment or the initial assessment. So rapid systematic approach to assess the ill child, teach them to the nurses, focuses on only these 3 main areas. These correspond with the assessment of the nervous, respiratory, and circulatory systems. So appearance, breathing, color, or appearance, work of breathing, and circulation. So what does it say? Suppose a child comes with a respiratory distress, so you can fix the organ. Suppose a child comes with a shock, you can say the circulation and the heart is a problem. So altered loss of consciousness or acute loss of consciousness, the brain is affected. So this is how you teach them and tell them how to triage. So the pediatric assessment triangle is you can identify the child which is seriously ill so that you can give immediate treatment. Only one word answer, you require only 30 to 60 seconds. Conscious or depressed conscious. Breathing is normal or abnormal. We'll go in detail later. So that whether the circulation is normal or inadequate. So the assessing the appearance. When assessing the appearance, allow the child to remain with the mother or the caregiver. Keep in mind the age and development that is normal for that particular age. Child with normal appearance, we'll see. Toddler who responds to his mother, attentive and interesting to the surroundings, readily consoled, good muscle tone and a strong cry. So, see, you can hear, so you can see the distractibility, alert, reaching for the toy, and the social smile of the baby. So, by appearance, you have to look for these things. Is the child ambulant or carried? Is the child unresponsive or altered sensorium? Is there a limited eye contact or a good one? Does the facial expression or body language indicate pain? What is the skin tone or color? The gait slow or rapid, absent or demonstrating signs of weakness. So this is a normal child, good interaction, eye contact, consolability. So assessing the appearance who is abnormal, whether this baby is agitated or is there irritability, poor eye contact, whether there is normal activity or a decreased interactivity. So drooling, inconsolable cry, vacant stare, these are the things you can pick up. Weak or high-pitched cry, a muffled speech. If this are abnormal, you go to the primary assessment. So these you can see by the nature of appearance itself, you can identify. So the pediatric assessment will go with the appearance is over. Now we're going to the breathing. Work of breathing, a ventilatory effort which tells whether the child's oxygenation and ventilation is adequate. Assessment includes body position, visible movement of the chest and abdomen, respiratory rate and effort, audible airway sounds. So you classify this whether it is normal or abnormal. Now abnormal, we'll see these three kinds of breathing by a video. So breathing, we'll see it begins by listening to the audible respiratory sounds, gasping, grunting or snoring or stridor or wheeze. A labored breathing, whether unable to complete sentences, whether the contractions are in the suprasternal region, intercostal, subcostal, clavicular or substernal regions. Is a nasal flaring. So you can, by the body position also, you can say shallow breathing means it needs immediate respiratory support. Labored breathing means it needs immediate intubation. So if there is these findings are seen, you have to quickly go to the primary assessment. So we'll go to the videos.
என்ன 100 ml bolus ஒரு லைன் போடலாம் மாஸ்டர் லைன் போட்டு blood ಶುಗರ್ ಅಂಡ್ ಇದೆ ಅಂದ್ಬಿಟ್ಟು ಎಲೆಕ್ಟ್ರೋಲೈಟ್.
So the third leg of the triage, circulation, it reflects if the cardiac output and perfusion of vital organs are adequate. Flushed skin usually denotes it can be due to fever or heat exposure and toxin. A pale and cyanotic or mottled skin suggests inadequate oxygenation, poor perfusion, or both. So I'll show you the picture. You can see here the baby's palm, which is pale, and see the examiner's, which is palm, which is pink. And here the legs. See the difference? The pink, which is normal, here it denotes the indicative of shock and pallor. So you can compare with your own hand. So the rapid triage assessment, appearance, whether it is normal or abnormal, breathing, circulation, takes only 30 to 60 seconds. So you can see whether it is by these three parameters, you can say whether it is stable, whether it is respiratory distress, failure, or a shock. So remember, any abnormal finding in any area of the assessment indicates that the child is sick and it requires immediate attention and intervention. Remember that the child's condition can change any time. A child that initially appears not sick may rapidly deteriorate and become sick. So frequent observing is necessary and reassessment is really needed. So this is the second step, A, B, C, D, E. This has to be by the doctor and the treating pediatrician. So we'll skip this. It needs a need. It takes about 1 to 5 minutes. So you have to take this pertinent history, and the vital signs have to be measured. You can take the other history, fever or pain. So what are the emergency required equipments and drugs required, and what they should be available to be functioning? Ambu bag, ET tubes, laryngoscope, suction apparatus, pulse oximeter, defibrillator, oxygen source, ventilator, etc., and all emergency drugs have to be there. So whether we are prepared, let us have a self-assessment by this acronym. Say SOAPME. Suction, oxygen delivery, airway adjuncts, protocols, medicine, and the equipments. So this is how we have to go ahead. And this is optional. You can have a large play area if you have space. And for the inpatients and the outpatients, you can have, and you can have it colorful. And thank you for the patient listening. And thanks for the opportunity.